if you cannot have what you like, you must like what you have. So you have me today. And I'm going to talk about the experience of an Italian NGO called Emergency, whose founder is Dr. Strada. And you all know what Ebola is, so we will not spend time on that. I like this slide because it shows that Ebola is not very contagious. An average Ebola patient only infects 2 people, while measles, as an example, the average diseased person infects 18 people. Unfortunately, the phytoviruses of the Ebola kind have a very high mortality. Left to himself, the disease runs between 50 and 90% mortality rate, which is one of the highest known. In comparison, the H1N1 epidemic or pandemic of influenza ran a mortality between 0.01, 0.03%. There was, and there is no specific treatment for Ebola. So the management of the patient is just to try to provide the best supportive treatment. Initially, the best supportive treatment was simply do not touch. Then this is a paper on intensive care medicine published early in 2015. I think it was something like January, late December. Going from fixed fluid replacement, because the initial therapy is simply fluid replacement. And from then on, you proceed to electrolyte checking, circulatory assessment, test calcium and magnesium, oxygen. When I arrived in Sierra Leone December 13 or 15, I don't remember exactly, stayed there 1 month. Very short time. But I was really surprised. In all West Africa, you could not find a tank of oxygen, or an oxygen tank, if you prefer. So in this paper, Perner, Fowler, and other colleagues advocated the use of intensive care for Ebola patients. As a matter of fact, the patients that were airlifted to the West had a mortality lower than 25%. In Africa, at that time, mortality of Ebola ranged about between 50 and 75%. So, Emergency had already, since many years, some 20 years, a pediatric surgical center in Goderich. And the first problem was how to keep the hospital running within the Ebola treatment. So this was the first holding center for Ebola patients. The Ebola patients have to be isolated and tested for positivity to the virus. It takes a variable amount of time to get the results, between 4 hours if you have the lab on site, 24 to 48 hours if you have to send the blood around, and then you still have a rather high probability of false negative during the first couple of days. So patients were kept under a certain number of tents. I think, if I remember correctly, we had 10 tents for the holding and treatment center in Lacca, where basically what was done was fluid replacement, basic support, and diagnosis. And from then on, the treatment proceeded, evolved. By a laboratory was set up. An invasive fluid loading was applied. IV cannulation initially was seen as a very dangerous procedure, not to be applied. Emergency from the start put in underway invasive treatment as far as possible. And luckily enough, the UK government set up a number of Ebola treatment centers in Sierra Leone. And one of those centers was run by the emergency organization itself. And the place was structured in this way. We had a white zone open to every visitor, a green zone that led access to the so-called red zone. If you follow with arrow, people entered this tent here, where they were dressed to be able to enter the red zone. You worked in the red zone, dressed like an astronaut, and then you came out from another tent where the most difficult thing was to undress. This is the place. This is a tank of no, it's not perchloric acid. Sodium hypochlorite for disinfection. You washed many times a day. This is the dress we used in Goderich. And finally, since December 15, and that is one of the reasons why I got there, we started implementing something like a real intensive care unit. And after a couple of weeks, we had oxygen concentrators, one for each bed. We had even ventilators. We had renal support devices. We treated the organization, not myself. I was there just 1 month. The Ebola Treatment Center closed its activity at the start of June. They treated a total of 106 patients in this intensive 24 beds intensive care. The average age was 32 years. The interval between onset of symptom and the admission was less than 5 days. And this is the crude fatality rate in various age groups. And you see that still is around 50%. The virus infects and acts on most tissues. It's not just diarrhea. Diarrhea is not like cholera. It's not just a gastrointestinal disease. It goes on all organs, almost. Symptoms, you know, I will not spend time on those. We set up a protocol for standard monitoring, blood pressure, heart rate, respiratory rate. Each patient had a monitor for AKG, oxygen saturation, temperature, and in each patient, we measure the viral load. We had blood gases, either mixed venous or arterial. The arterial were only in approximately 45 patients. White blood cells, red cells, liver enzymes, kidney function, electrolytes, and tests for malaria, hepatitis, HIV, often concurrent diseases. You see here the kidney function at admission. Some were the survivors were admitted with a median creatinine level around 3, while the non-survivor had a median admittant level around 4. These are liver enzymes, alkaline phosphatase 5 times higher than normal, ALT and AST some 20 to 25 times normal, and so on. Coagulation was severely impaired in most patients. The Ebola infection was originally classified as an hemorrhagic fever. But I must say that a certain percentage only of the patient had hemorrhages compromising their probability of survival. These are white blood cells in survivors and non-survivors. You see the numbers of patients in each at each point, and you see that indeed the non-survivors had higher numbers, higher counts of white blood cells. We took a few X-rays, not many, because we had only one X-ray machine, and I expected to see ARDS sooner or later, but I did not really saw anything like a real ARDS. This is the lab. The lab was very difficult to handle. We have specialist people coming from Italy, from the National Institute for Infectious Diseases. And everything has to be done with standards, safety standards very stringent. This is my last slide, and it tells us something very important. We care for those patients, but those patients got better or did not get better according to their ability to fight the virus. The non-survivors started with a higher viral load, and the viral load stayed high up to 15 days. While the survivor one had started with 10 times less viruses in average, but the virus load started to go down after 6, 7, 8 days. And we don't know what makes the difference. We don't know whether this is immune response or this data will be soon published on the Journal of Clinical Investigation. And well, it's a common data from many laboratories. The viral load is the most important determinant of survival. We learned a few things. Ebola virus disease is a disease that differs a lot from patient to patient, affects most organs and systems at different times, in different sequences, in different patients. Strict monitoring and best supportive care of those patients is essential. Intensive care is mandatory in most of those patients. At least 50% of those patients require something like an advanced critical care unit. And well, that's it.
Thank you.